very quickly, Natalie's going to start the poll. And what we want to know is, what do you think a fall is? People will say, I don't fall, or somebody falled, and they'll say, no, I didn't. So, what's the technical definition? And while you're clicking and tapping, I'll tell you that I kind of smiled because my husband told me many, many, many years ago that like in skiing, it doesn't count as a fall unless at least one ski comes off. Well, we don't have that kind of thing that we can look at, but what do we consider a fall? And this again is partly your personal opinion. It also brings us to a definition that we're going to get to in just a few seconds. So Natalie, if you will go ahead and close the poll and tell us what our results are.
Hopefully you can see the sharing of the results. So
we can.
Great. So how many times have you or your loved one fallen in the past 12 months? Hopefully this is the question we're at. Yes?
It is.
Great. A good, it looks like 3 answered none. 4 out of our 10 participants in the poll answered once, and 3 answered 2 to 4 times.
All right, so that's kind of a spread of people that either haven't experienced any or that have experienced a lot. Fortunately, nobody, I think, checked the 5 or more, which is a good thing. So let's go to the next slide, Natalie, and we're going to learn what a fall is. Now remember, this is kind of a subjective thing, but when you look at this definition, there are some important parts to it. You can fall by changing your position to a lower position. Now, since we live on planet Earth, that's gravity, and so we always fall down. To the best of my knowledge, you can't fall up. Even in Australia, that's not a possibility. So that really is one of the things, is moving from one level to another. So if I'm sitting and trying to get off of a chair and I end up on the floor, that would be a fall. Of course, if I'm standing and I stumble and I put my hand out to the couch, but I'm now lower than I was before, that again counts as a fall. And I know that a lot of times people don't like to admit they've fallen, especially as people get older, because they're worried about what people are going to think, what they're going to do. Oh, I can't take care of myself anymore because I've fallen. I know that it helps to hear personal stories. And so my first one regarding this is that I am both blind and have MS, both of which make me at high risk for falls. And I have fallen, I believe, 5 times so far this year. Nothing terribly bad, fortunately, but definitely falls. And I didn't used to do that. And I know that it is directly related to those conditions that make me more prone to falling, because I either can't see things or I can't feel things and my balance is off. So let's go to the next slide, Natalie. So that's what we say, that falls happen to everyone and they happen everywhere. We are going to try to remedy that. We're going to try to eliminate falls. And most of that is cognition, being aware of your surroundings, of what your physical capacity is, those types of things. Not that it should overwhelm your life, but just to be aware of it. I use a cane to help me find things before I fall over them. That's a thing that blind people do to prevent falling over things. Others of us can do things like making sure our homes are just kind of clean and tidy, because one of the things we fall over a lot is stuff left maybe on the floor where it wasn't supposed to be. Okay, so right now, falls do happen everywhere and to everyone, but we are going to try to reduce or eliminate that. Next slide, Natalie. When we talk about Idaho, there's all of the Idaho statistics, and for falling, it sometimes is hard to get the statistics because a lot of people don't report falls. Like we just said, they don't consider it a fall, or they're afraid to tell somebody that they had a fall, especially somebody in authority. But here you can kind of see how Idaho compares to the rest of the country as far as falling. We want to reduce that even more. Okay, so that's what our goal is now. Next slide, please, Natalie. So before we move on, we just want to know that falls tend to increase with age, but we say so much at Commission on Aging that a lot of things are not part of normal aging. We consider them to be because they happen to most people, but we actually can do things to prevent them. Falling is one of them. That's why you're here. So we don't want to make aging the reason that you or your loved ones or your family and friends fall. Next slide, Natalie. So what exactly are the risk factors for falling? Well, I think we all kind of know what they are if we think about it. If we have things in our way that aren't normally there, or we're not familiar with the environment, we didn't know there was a step down and we didn't see it. We also can have, of course, physical conditions that impact our falls. Like I said, MS and diabetes tend to do that. We also can be taking medications that might make us fall. And, you know, if any of us have ever taken a prescription pain medication, you know, it kind of makes you groggy and loopy, as some people say, and that would make you more prone to falling. As will malnutrition, dehydration. If you've ever been sick and had the flu for a few days, you know that when you get out of bed, you're unsteady. So all of these things that you see could be risk factors for falling. Again, be aware, be mindful, and avoid all of these hazards. Next slide, Natalie. So with all of those statistics and things, you're probably going, oh my gosh, I'm doomed. Falls are inevitable. They happen everywhere to everybody. There's so many of them. It just is what it is. I have never settled for it is what it is. I think it is what we make it. So the good news is we do not have to fall. We can learn techniques, skills, and some techniques to reduce or completely eliminate falls. Next slide, please, Natalie. All right, so when we talk about avoiding falls, that really is, you know, where there should be a huge stop sign. It's like, just stop. Whatever the risk is, let's stop it. We have the control, with the exception of maybe some chronic conditions and medications, but at least we can be aware of those impacts. So avoiding falls is the key to this. It's not something where you can say, well, I fell a little bit. Next slide, Natalie. All right, that's good for me for a while. Now we're going to let you talk to the actual pros. We need to understand not only what the falls really are, how many we have, what the risk factors are, but how it impacts us in so many ways. And so to do that, we are going to have Dr. Jessica Zebarth from the First Medical School in Idaho give us a little bit of information about understanding something called the falls cycle. Natalie, Great. If you go to the next slide, hang on just a second. There we go, you're on. Take it away, Dr. Zebarth.
Thanks for inviting me today to talk about falling. So while we're going to talk about the devastating physical consequences of falls later in this presentation, let's first start by talking about some of the psychological consequences of falling. The fear of falling can be a negative psychological consequence of falling. The fear of falling, also known as FOF, can also be termed post-fall anxiety syndrome by health professionals. The fear of falling is actually quite common. In one study, 1 out of 3 women aged 70 to 85 had a fear of falling. And in a follow-up questionnaire 3 years later, researchers found that this number actually increased to 50% of women who had this fear of falling. Now, fear of falling is most positively associated with previous falls. So that means that if you've fallen in the past or you have a history of falling, you're more likely to develop a fear of falling. However, you don't have to ever have fallen in the past to actually have or develop a fear of falling. And fear of falling is actually associated with other medical conditions such as depression, poor mobility and poor balance, maybe some cognitive decline or poor memory, extra weight or obesity, and those of us who live alone. Next slide, please. So fall-related efficacy is a medical term that health professionals will use to describe how confident a patient is with moving around and getting around at home. So if a patient has high fall-related efficacy, that means that they're pretty comfortable walking around on their own with very little fear of falling. On the other hand, if a patient has low fall-related efficacy, this means that they do not feel confident moving around on their own, and that can really limit their independence in the household. Fall-related efficacy is influenced by this fear of falls. And that makes sense because if you are anxious that you might fall, you're going to feel less confident doing your activities of daily living, such as cooking and cleaning, getting ready for the day, and even going to the doctor or going grocery shopping. This might lead to people not doing the things that they would like to on their own, and that limits independence. And all of this really happens because of our low fall-related efficacy and our fear of falling. Next slide, please. So as we've already talked about, fear of falling is associated with a decrease in physical activity and daily activities of daily living. If you look at the image on the right, this is what clinicians call the fall cycle. And the fall cycle really helps us understand several risk factors for developing falls, as well as ways that we can intervene to prevent falls from happening in the first place. Notice that fear of falling is part of the fall cycle. Fear of falling may restrict patients' movements, and patients may be less likely to keep physically active due to the anxiety regarding falling. This in turn will lead to poor mobility and low activity levels, which we know has negative impacts on patients' abilities to function independently. Fear of falling also leads to this poor mobility, decreased muscle strength, and poor flexibility. And in turn, poor mobility and low activity levels influence other health factors like the development of chronic health conditions that can further contribute to increased fall risk. The CDC states that 4 out of 5 of the most common medical conditions in adults ages 50 and above can actually be prevented or managed with physical activity. And there are a lot of reasons why poor mobility may be associated with chronic health conditions. Dr. Sear and Dr. Bates are going to fill us in on some of those aspects later on in this presentation. So in summary, the fear of falling can lead us to doing less, becoming weaker, having worse balance, and that can all contribute to chronic health conditions that will increase your risk of falling. This whole cycle, including the fear of falling, poor mobility, and chronic health conditions, creates a very vicious cycle, and it can create a very difficult situation for families, caregivers, and patients. Next slide, please. So sometimes the fear of falling and the anxiety regarding falls can limit people's abilities to enter the community. And it's even been reported that some patients fear falling so much that they basically become confined to the home, not really wanting to leave. Fear of falling can lead to social isolation, which can further lead to reduction in healthy activities like seeking preventative medical care and regular checkups. Oftentimes, patients can feel so uncomfortable with walking in their own home that they stop cooking and making meals for themselves, and that can result in poor nutrition and poor hydration. And in clinical practice, I've seen some very severe cases of fear of falling that basically limits patients to their beds or their recliner in some very severe cases. The fear of falling is also associated with depression, and patients with the fear of falling have a higher likelihood of developing depression as well as activity restriction. And obviously, you can imagine if you don't have the confidence to do your activities of daily living, you aren't comfortable moving around and independently functioning, you're going to have impairments in quality of life. Next slide, please. So as a clinician, I oftentimes will look at the fall cycle, not only to explain what causes patients and contributes to patients falling, but it also lets me look at interventions and treatments to decrease a patient's risk of falling in the first place. And that's why it's so important for patients to work with their healthcare team for guidance, because your healthcare team can specifically tailor a program for your needs. Balance training, low intensity exercise like Tai Chi and chair-based therapies, and a fall prevention program have all led, all have evidence that they can decrease the rate of falls. And they can also improve patients' confidence and fall-related efficacy. So that in turn might lead to a decrease in falls. Additionally, some patients with a very severe fear of falling might benefit from a referral for cognitive behavioral therapy to help deal with the psychological aspects of the fear of falling. Next slide.
Thank you, Dr. Zebarth. I will take it from here, and thank you so much for that great presentation and the lead-in, Erin. We really appreciate it, and it's so good to be with you. I'm Dr. Rodney Bates. I'm primary care chair at ICOM, as well as serve as a hospitalist at St. Luke's Nampa Hospital. Next slide. So I really want to really get your thoughts, and we'll go ahead and pop up this question from Natalie in terms of physical outcomes. So I think we got your discussion around how many falls potentially within the last year, how many have suffered an injury, and was that injury significant? So we're going to be focusing on the physical outcomes of falls. We know there is a lot of psychological issues around falls, as stated. So it looks like fairly significant. So a fair number of hospitalizations as well, which can be very concerning, including significant resource issues around falls. Next slide. So ending up in the ditch, what does this refer to? This is actually kind of going along the process of our minds are a little stronger than our bodies. And in my own grandfather, who after, bless his soul, getting a knee replacement and thinking he could do a little bit more on the farm, decided he would try to jump a ditch and completely messed up his new knee and had to get that repaired. That led to further decline in his overall health. And this can happen to any one of us as we age. We obviously feel like we can do more than our bodies will physically allow us to. Next slide. But what is the overall physical impact, and how does this impact not only the individual, but also those caregivers, those that are surrounding us in terms of our family members? Next slide. So if we look at some of the physical effects of falls, anything can happen in terms of skin damage. My mother had a recent fall this last spring where, and she is a very active individual. She was out gardening and decided to try to go up steps and ended up with quite a significant bruise around her eyes and her head that lasted for quite some time. These can be visibly concerning, as well as potentials for infection with such things as skin tears. Significant bruising can lead to bedbound status, as we've heard, with further fear of falling, which can lead to other physical effects such as bed sores, developing just sores from pressure of sitting. Also recent or risk of infection in terms of other barriers that we have in our environment is our main barrier to infection is our skin. Next paragraph or next slide. So obviously the one that we think about a lot is bone fractures, and big ones are the pelvis or hip, and also our spine, particularly the low spine or mid spine for many individuals, and those can happen just from not our typical fall to the ground, but even just losing strength and sitting down very harshly on a chair that may be a little too low. So as we think about things that we can do to avoid those, these are certainly some things that are significant. And we know that hip fractures may cause a decreased lifespan of up to 50% in the first 5 years after a fracture, which is extremely high risk. Next slide. Obviously, head injuries can also be a significant concern. These can lead to fractures of the skull if we hit hard enough or significant enough. Concussions can occur, which can lead to further confusion and further falls. And then the dreaded brain bleed, which can land a person in the hospital with various symptoms in terms of our neurological compromise, and may require obvious other interventions to be done while in the hospital. Next slide. Other common outcomes that we think of more commonly in terms of significantly reducing our ability to get by from day to day would be pain, obviously loss of function with getting dressed, providing ourselves with even the desire to walk across the room or to continue to strengthen or be active. If you're in pain or discomfort, you're going to try to diminish your levels of activity. And then, of course, that increased risk of future falls because we do get weaker. Next slide. So there has been studies around those individuals who, after a fall, require hospitalization, and where do they go from there? So if we look at after hospital outcomes, half required placement in such as a nursing home or a care facility of some kind. Only 1 in 3 of those who were considered elderly or older status were able to go home without assistance. 6% go home even with assistance of some kind, usually home health or other physical therapy needs. 5% needed a complete rehab facility, and half were eventually readmitted. So that risk of further falls, risk of further decline certainly is there. If we look even further out, those with 1 year after injury, only 1 in 4 are completely discharged from these facilities, and 1 in 3 died. Again, that increased risk of death. So there is definitely an increased risk, especially those that end up needing admission to facilities. It's 3 times greater. Next slide. And I know these can be scary statistics, but they do underscore the need to decrease and prevent falls, absolutely. Fall death rates in the US have obviously increased in older adults, as our population ages, as our population increases in that age bracket. Certainly we're going to see this continue to go up. And these are sobering statistics if we look at the CDC website. And if rates continue to rise, into 2040 and above, and 2030, 7 fall deaths per every hour, that's quite impressive. Next slide.
All right. Well, thank you very much, Dr. Bates. We're going to give you a chance to take a drink of water and breathe for a second, because he is going to continue talking with us about how medications can impact. But I just wanted to say that, I've been through this material many, many, many times for a couple of years, and still when I hear it, it's scary. And remember, we do not want to scare people. This is not about shock and awe, but it's about bringing the reality and learning and understanding why it's so important that everybody understands how to prevent falls. So with that said, Dr. Bates, are you ready to tell us a little bit how medications can impact our fall risk?
Absolutely. We'll move on to the next slide. So again, let's share some thoughts on an individual basis. And if we can pull up the poll here. So what type of medication do you think can increase the fall risk? And you can choose more than one on this list. Actually, I think you can only choose one. I apologize.
You should have been able to choose more than one, but you know, technology. And again, while they're filling this out, I just like to interject again because, boy, geez, how long ago? It was 30 years ago now or so. I took a medication and had no idea what the impact was. And all of a sudden I was having like anxiety attacks and I couldn't stop crying. And it turned out it was simply a side effect of the medication. So, you know, they can do really powerful things that are good for us, but also some other things that Dr. Bates is going to talk about. So Natalie, why don't you go ahead and close that out and let him continue.
So pain relievers. So we've been well indoctrinated on what these can do and what these can cause. You know, obviously, we hope that's not Tylenol or ibuprofen, but certainly in terms of opiates, absolutely. Next slide. So medications are truly a balancing act. You know, we have prescription medications, we have medications that we can take commonly that we wouldn't think would have significant effect on our overall abilities or our overall decline. They can be over the counter, you know, liquids, creams. These things can still absorb and cause interactions or other issues with our overall ability to continue forward. You know, vitamins, eye drops, dietary supplements, they all are not immune from causing issues in terms of our overall side effects. Next slide. So what do we talk about when we do visit a provider about fall risk? And this is one thing in evaluating fall risk that physicians, APPs, any healthcare provider has been trained in to ask certain questions, but also of the patient side, you know, what kind of questions can I ask to prevent potential risks with certain medications, especially if a physician or healthcare provider does not know what other supplements or medications you may be on. So what do I do if I have a problem? These are important questions that you can ask your provider. You know, what should I be aware of with this medication? Are there any risks or side effects that should be expected? Next. So medications that affect blood pressure obviously can affect fall risk, and anything that typically drops blood pressure would be of particular concern because once we stand, we can become very lightheaded. It takes a while for the blood pressure to reach the brain. This would be what we call orthostatic or postural hypotension, just meaning low blood pressure from standing quickly or going from a seated position to an upright position. And multiple things can affect that, including blood pressure medications, water pills, where we become somewhat dehydrated and maybe our balance is not correct in our intake versus our output of liquids. Also, electrolyte imbalance can affect blood pressure and the way the heart and the heart muscle works, as well as our vessels and how well they constrict or do not constrict. And medications that can improve urination, such as tamsulosin. This would be commonly used in males for benign prostatic enlargement, where decreased ability to urinate is an issue. And there's multiple others as well, but we know that high blood pressure is a silent killer. It is an aggressive factor that is mediated from a medical standpoint. But just remember that the impacts of decreasing blood pressure can be significant, especially in our elderly population. Next slide. So what about those that can affect blood sugars, and typically these are diabetics or nearly diabetic patients that may be on medications. And obviously, if your blood sugar is low, first thing you try to do is get up and go find a snack or food. And before we know it, we find ourselves on the floor or having a seizure. There's all kinds of issues with extremely low blood sugar. Also, not to diminish high blood sugar as well. Certain things can happen with high blood sugar, such as dehydration, as well as other issues around balance. And these are just some medications that are used for blood sugar control that can have significant concerns. Next slide. And what about those that affect our ability to either, one, think clearly, two, our cognitive or cognition effects around reasoning or providing ourselves the connection between our brain and our legs with being able to continue forward, psychoactive medications or those that are used for restlessness. We looked at risperidone, quetiapine. These are just some medications that you may or may not recognize. It's okay if you do not. But certain categories of medications, such as sedatives, benzodiazepines being one of those, which is commonly used for anxiety and immediate anxiety. And these are common medications that have been used quite a bit in the past that we know put people at risk of falls, especially those that are already at risk. Next slide. So if we continue this out even further, anti-seizure medications, antidepressants, any of these class of medications can increase risk of falls. The lists are enormous. These are just some sampling of potential medications that can be very, very detrimental, but very helpful in the same line. If you think of anti-Parkinson's drugs, things that you think would improve fall risk in a Parkinson's patient may also lead to falls. So these are things that just need to be balanced with a good healthcare provider and just open discussion about what is occurring. Next slide, or next paragraph, next slide, sorry. Anticholinergic, these are medications commonly used for allergies and can cause dry mouth, dry eyes, cause dehydration. Again, if we're not taking in enough liquids, over-the-counter sleep aids can have these in them. Tylenol PM, ibuprofen PM, which is out there in certain formulations. These medications can cause these types of issues with balance and ability to get around. Benadryl is diphenhydramine. It's a very common over-the-counter allergy medication now. And these are things that you wouldn't think would have that much effect, but they do. Next slide. And of course, many of you answered the query about pain medications, and these can be a problem both for prescribers and patients in terms of how we deal with pain. It's obviously one of those things that we want to alleviate for patients, at least to some degree. But opioids, in terms of our past and our future aggressive desire to avoid opiates at all costs, there is a need for opiates still in terms of chronic illness and chronic pain requirements. They can become addictive, we know that, but they can also increase risk of falls in terms of both the psychological effects as well as ability to get by with our strength, balance, what have you. Non-steroidal anti-inflammatories, I know we said we hope that one is not associated, but it can. You can get blood pressure excursions, again, with these types of medications. So there's multiple potential effects even with those. Next slide. And if there is a need for pain medication assistance, you can dispose of these in appropriate locations, get professional help for any types of abuse of opiates. Chronic pain management is important. There can be referrals to specialists that deal with chronic pain that are very willing to help in terms of these and also help decrease risk. More is in the resource guide. Next slide. So what can we do overall? If we do find that a medication is causing side effects, is increasing our risk of falls beyond other potential side effects. We can stop those, but always seek the care of your healthcare team. Sometimes just stopping medications rapidly is not good, especially in terms of the antidepressants and other medications that may have other issues around stopping abruptly. It's always good to get the advice of your healthcare provider in stopping medications that you feel really are affecting your ability to not fall. Also ask the prescriber for safer alternatives, and this can be done even with our pharmacist colleagues who are very well-versed and capable at describing these things for you up front. Reducing the dose sometimes is very helpful. Again, this would come from advice of your physician or pharmacist. And it really should be a team effort with you as well, included as the patient and as the person taking that medication. Next slide.
Well, thank you very much, Dr. Bates. Please sit down and rest for a few minutes. That was a lot of excellent information, but I know when you talk for a while, you got to take a deep breath. Geez, you know, medications are hard because my husband used to say, I'm the only nurse he knows that doesn't believe in medication, and that's not true. I believe in medication when it's appropriate. And so many people, especially some of our older adults, aren't comfortable. They feel like challenging their physician. You know, what does this drug do? Why am I taking it? Are there other options? So we really need to open up that communication, as well as being aware of what medications are doing for us and to us. So with that said, we're now going to move on to food and water. And we've mentioned many times since we started how important hydration and nutrition is. So we're going to let our wonderful Dr. Cindy Seeger take this one on. She has a whole bunch of letters after her name, but what they all really mean is that she has a passion for making sure that people can be physically well. So Dr. Seeger, take it away.
Thank you so much. All right, so let's go ahead and move to the next slide. So as this one says, everything truly does affect balance, which affects your ability to stay upright during the day. So I have some photos here. The first one on top left is about sleeping. Everything affects everything. Your quality of sleep, how much you sleep. The bottom three are all about your shoes. What shoes you wear affects your balance and will affect your fall risk. So obviously the ones on the bottom right, no matter how cute they are not great for people's balance. Even slippers, the middle one, are not great for balance because they don't control your foot. And so you're more likely to slip in things like those. What we're going to talk about this one is food and water. Hydration. So in this section, I'll talk a little bit more about sleep and shoes in my next section. So next slide. We all need proper nutrition. We all need to keep our bodies fueled. We know that as we get older, we have a change in body muscle fat ratio, but most older adults have difficulty with nutrition. Many of them are either undernourished or malnourished. This could be several reasons why, whether it be teeth, you can't chew your food, you have difficulty swallowing, you have other systemic issues, you have to have specific diets that limit your food choices, or it could be money. You just can't afford food. If you have to choose between food and medication, which do you choose from? So we do know that nutrition is vital for staying upright and preventing falls. And many of us know about the relationship with blood sugars and diabetes, but we don't also realize that we also need vitamins and minerals, protein. We do need some carbs and sugars to keep our cells healthy, to keep the nervous system healthy, the muscular system healthy. All of that, we need all of that to stay healthy, and it's vital no matter what our age is. Next slide. All right, we have a poll. How many cups, not glasses, of water do you drink a day? You could pick one.
Dr. Seeger, this is Erin, and I just like this question and want to clarify that question isn't about liquid. It's about water. So your Pepsi and your coffee and maybe your beer, those don't count. We want to know about water itself. And I know it can be hard to estimate sometimes, but do your best. And we'll end this poll in just a couple more seconds and find out what your responses are.
We will accept flavored waters, but
Okay.
it has to be water, primarily water. Go ahead and close the poll. So most of us are drinking between 1 to 1.5 quarts per day. And that's fabulous. Hopefully everybody does drink some water. Go ahead and next slide. When we're looking at drinking water, a lot of people will try to get their liquids in other forms. And Erin did say coffee, alcoholic drinks, sodas, they all have water in them, as does milk. Milk is actually considered a food, not a water, which sounds strange, even though you drink it. But for every cup of coffee you drink, it dehydrates you. And so you need 2 cups, same size, of water to offset the dehydration. And water is vital. And I don't know about many of you, but I don't really like the taste of water. And so it makes it difficult for me to drink, which is why I tend to do flavored waters, sugar-free flavored waters. But as we get older, our thirst mechanisms in the back of our throat actually get less sensitive. And so most older adults are dehydrated already. The research is already out there saying that most older adults already are dehydrated. And then you start having your daily activities, and then maybe you have urinary incontinence, you can't make it to the bathroom in time, and all of these other issues start impacting your hydration, and it all leads to falls. And if you do have urinary incontinence, you need to actually drink more water. It helps decrease you're having to go to the bathroom more frequently. It sounds counterintuitive, but it is. But we do know that when you get dehydrated, you end up you're easier to have injuries. If you do hurt yourself, you can't recover as quickly. And so how much water do you need? The answer is it depends. What are you doing? What time of year is it? Are you outside or inside? Is it hot? Is it 95 plus? You're outside at a picnic with your family. You need to drink more water than if you're inside in an air-conditioned unit and watching television. You don't need a lot of water there. So how much do you need? You drink 6 cups a day, or how much do you drink? That all depends on your activity level, the heat, all those other things. So pinch your skin. And if your skin doesn't go back to its normal, how it looks normally, then you're dehydrated. So drink more water. If your lips start chapping, drink more water. All in all, drink more water. Your body will naturally balance out the water content. Next slide. Signs of dehydration. Confusion is a big one, being lightheaded. Many of these, we don't know what the reason is. Many times we'll wake up in the middle of the night and we're hungry. We're not hungry, we're thirsty. Many times when we think we're hungry, we're actually thirsty. And so drink some water before you grab food to make sure it is not dehydration. Next slide. Alcohol. People drink alcohol, but alcohol will dehydrate your system. And so for every glass of wine you have, you need 2 glasses of water, same size as the wine you had, to offset the dehydration. We also know that alcohol depresses your mechanism to feel hunger. And so you're less likely to eat healthy if you drink alcohol. 1 or 2 cups, depending on your size, male, female. It depends on how much is really good for your body. But alcohol, shouldn't be drinking alcohol with a lot of medications to begin with. So I try and tell my patients to avoid alcohol as much as possible because of all the different problems it can cause. Next slide. What can we do? Eat a nutritious diet. I'm sure you're all tired of hearing eat a better diet. Eat healthy. It's okay to eat a donut, depending on your health condition. But for most people, 1 donut's not a problem. Eating all 12, that's the problem. But having a cookie on occasion isn't a problem. Eat regular intervals, know how your body reacts, drink the appropriate amount of water or flavored water, know your signs of dehydration, know how your medication affects your diet and your hydration. Some medications actually dehydrate you, other ones don't. Next slide.
All right, well, we're going to let you take another break like we did with Dr. Bates before you start with your next section. I learn something every time we talk with these experienced professionals, and I love your tips about the 2-for-1 ratio, as well as the skin pinch. So that's a good deal. Are you ready to take on our next topic?
I am.
All right, let's go.
All right, we have another poll. If you could show that poll, Natalie. Which of the following do you think contributes most to falls in older adults? This one does say single choice. This is an opinion one. And while I will say all of them do apply, which one do you think is the most important when it comes to preventing falls?
Now, Dr. Seeger, you're not supposed to tell them the answer yet.
I didn't say which one. I want to see what their opinion is.
Yeah, you said
I did say
all,
they're all
but yeah,
important. You're right, but which ones do they feel is most important? Because
exactly.
again, we'd like to have an choose all that apply. All right, so you should be able to see the results. Loss of muscle, decreased strength, reduced endurance, limited flexibility, diminished sense of balance. All of them do apply. Loss of muscle, we'll talk about that's sarcopenia. And it does relate to strength, but you can actually lose almost 80% of your strength before you even realize that you're weak. So loss of muscle, it does impact it as just strength, but how much it impacts it, you can actually lose quite a bit before you notice it. Next slide. All right, staying powerful. We talked about strength and muscle. Next slide. Strength as we get older is not as important. I'm not saying you shouldn't strengthen, but we do know that we do have muscle loss as we age. Normal, it's minimal. If you stay healthy and active and you stay strengthening, so doing activities that continue to work on strengthening activities, you have very little muscle loss as we age. It's not considered technically normal lossing. So we have two types of sarcopenia. Sarcopenia is loss of muscle mass as we age. And there's two stages. Stage one is the normal minimal loss that we get. We have people that are 100 that can, deadlift 300 pounds. That I can't deadlift 300 pounds. I don't want the deadlift 300 pounds. OSHA is 50. We're fine. But it is reversible. And most of the time, stage one is caused by disuse. We sit on the couch, we stop moving, we stop lifting the bags because of other reasons. And so the more you can stay active, the longer you can keep your muscle mass. Severe loss is not normal aging. It's stage 2 sarcopenia. It is irreversible and it's typically due to pathological causes. Most people have stage 1. Even as it gets more and more severe, we can make reverses if we get you active again. So getting you up, getting you moving, we can reverse the vast majority of muscle loss. Take the next slide. What we are more concerned about as we age is the concept of power, which is strength over time. How fast can you get out of the chair? The slower you try and stand up, the more strength it takes. The slower you try and open the door, the more strength it takes. The slower you try and do something, the more strength it takes. So you need less strength if you do it faster. Now, obviously, if you do something too fast, you might fall. But we are concerned about the concept of power. This is why when you're doing strengthening programs, you need to change the speed that you exercise at. Do something slow, do something fast. Do the same thing slow, do the same thing fast. Change the speed you do it so your body can produce the power, the muscle strength at the speed it needs for you not to need as much strength to get out of the chair. Next slide. Gaining strength, we want you to work 8 muscle groups a day. People are like, which muscles do I work? I'm like, muscle groups. So gravity is resistance. Do you need a gym membership? No. Should you have one? That's your choice. But gravity is resistance. So you can give a great workout just using gravity. You can use free weights. You can use machines, elastic bands, water resistance. You can use walls, chairs, household items. Gallon of milk is a weight. And go ahead and lift it a few times and you're going to get tired. So 8 muscle groups. So your bend your elbows, lift your shoulders, straighten your knees, bend your ankles. Those are muscle groups. We would talk about maybe do the bicep brachii, not do a muscle group. Do 8 of them a day, lift and hold, change speeds. And how many do you do a day? Do you do 10 reps? Do you do 20 reps? You do to muscle fatigue. If you fatigue between 8 and 10, well, 8 and 12, you're strengthening. If you fatigue between 15 and 25, you're doing more in muscle endurance. So you get to choose how many you get to do. If you want to go after muscle endurance, go between 15 and 25, but you go to fatigue. If you want to work on pure strength, go between 8 and 12. What is fatigue? Fatigue is you can no longer do it or your form breaks. You can't do it the same way you did it on rep 1. Okay, so go to fatigue, and that's the best way to gain strength. Next slide. Staying flexible. Decreased flexibility increases falls. Go ahead to the next slide. Now, some of us are more flexible than others. I'm not very flexible in certain ways, but as long as that flexibility doesn't change as I get older, things will be fine. It's when you start getting less flexible than you were in your 40s and 50s. That's when it gets difficulty. Balance needs to change as you change with different factors. Do you have different balance when you're sitting or standing? You have dynamic or static balance. So are you sitting still or are you walking? Walking is a dynamic balance. Are you walking over even or uneven surfaces? You need different balance. You have different balance when you're having good lighting versus poor lighting. So if you get up in the middle of the night, make sure you have night lights so you have lights, because your eyes are part of your balance system. Your inner ear is part of your balance system. Your skin sensors and your joint sensors are part of your balance system. And so if you're having trouble with a particular part of balance, get into a PT and we can figure out what it is, which system is giving you the biggest problem. And we can give you tools and techniques to help resolve those problems, because balance should not truly decrease as we get older unless there's pathology. Now, our reaction times slow as we get older, so we rely more on what's called anticipatory balance, anticipating problems versus reacting to problems. And so we know as we get older, it's icy outside, we should take steps to prevent falls, versus younger, you see 2-year-olds just run outside and down they go. They don't think ahead, whereas as we get older, we start thinking ahead. And that's an important skill to do. Next slide. Aging and falls, we need to maintain all of them. Mobility challenges. As we get older, we end up with chronic problems. And we're going to talk about those in a little bit. But the last stat I saw is 75% of people over the age of 65 have at least 2 chronic conditions. And that's kind of scary. But pain in joints leads to decreased flexibility, maybe even decreased pain. We know that even 3 milliliters of excess fluid in your knee decreases the strength of your knee muscles. It does. And so things like that can cause problems, but falls cause isolation. If you're isolated, you're more likely to be lonely or depressed, which is a big downward spiral. It just spirals. So stop the cycle. We can stop this cycle and we can slow things down and keep you healthy longer. There you go. Next slide. Take a class. We do know you're more likely to exercise and stay active if it's social. If you have friends that you go see and friends you go do, it's hard to stay active with a walking program if you're the only one walking. If you have a friend that walks at the same speed or a little bit faster than you, then you're more likely to go walking with them. We have Fit and Fall Proof statewide. It is a program that is statewide. Find a program. We have Silver Sneakers. We have other things that are out there. Get active, stay active. Do things that are functional. So if you need to, practice lifting that gallon of milk in and out of the fridge. That's functional strengthening. If you need to, work on getting out of a chair. Do it several times, well, several hundred times a day. That's functional strengthening of your lower limbs. So stop the cycle, get involved with things, get involved with other people who are active. You're more likely to be active if people you're around are active. Next slide. Right there is 6 simple exercises to help you stay active. You can access that via YouTube. I can't say more about staying active. The worst thing we can do as we get older is to sit down and watch television. Not saying television is bad, but the more you sit, the less healthy you're going to be. Next slide.
Audio now unmuted.
And I'll just leave that quote. And exercise is more than just going to the gym. Exercise is any activity, gardening, household chores, going for a walk with your loved one, taking care of your pets. Any activity is exercise. Stay active. Erin, over to you.
Yes, ma'am. And boy, remember everybody that all of these important things are going to be in your resource guide when you have access to it tomorrow. And like our prior panelists, I just sit there and listen, go, And the thing that I find interesting is that most of what we talked about to this point is what we've heard, hopefully, from our parents, for example, all our lives. Eat a good diet, drink lots of water, get up and move. But I think it's this understanding about why that's important. Because when I drink a glass of water, I don't feel any better or worse usually. When I stand up and sit down, I don't think about all of the impacts that's having either. So it really is important to understand. And that's why we put this particular presentation together. So Natalie, let's go to our next slide, please. Okay, now we are going to kind of combine all of these concepts that we've talked about, the fear of falling cycle and the physical impacts and the psychosocial impacts and the nutrition and the movement. And we're going to put them together into a little package that talks a little bit about chronic conditions. Like Dr. Siebert said, the number of people that have 2 or more chronic conditions in the United States as adults is incredible and not in a good way. And the vast majority are actually right at the majority of adults that have at least one. And many of those conditions can either be improved. Symptoms can be improved. Sometimes we can reverse them, like type 2 diabetes is sometimes reversible if we do the right things. But we want to know how these conditions specifically impact our fall risk. So let's go to the next slide to get started. And I'm going to ask real quick, Dr. Zebarth, are you still with us or did you have to leave?
I think she left.
Okay, she had an appointment. So that means that we have just a couple of panelists that are going to be able to help us work through this, but I'll talk too. So, you know, that's always a good thing, right? Let's go ahead and show the poll, Natalie.
7. Exercise.
We want to know about exercise. What do you think? And you know, as we've gone through this, hopefully you're being able to focus in on the right answers, if there are any. That's what knowledge does for us. But again, sometimes we're just asking your opinion and there's no grade here. We just want to know what you think. And we're going to go ahead and cut this one off fairly quickly. Natalie, if you could read us our results, then we'll move on.
Yeah, in the question asking what barriers do you or your loved one have to participating in regular physical activity? Looks like time, motivation, transportation, cost, and just not knowing where to begin or where to go were our answers.
And you know what? Not unexpected. And it really depends on the person. You know, I live in an area that doesn't have any public transportation. Like I said, I'm blind, so I can't drive. So that's a barrier for me if I want to go somewhere to exercise, which I really like to do.
Stop my video.
All right, Natalie, let's move on to our next slide. And this one is about diabetes, which is unfortunately almost becoming an epidemic level, especially with type 2 diabetes. We're even seeing it in younger people. But as it relates to fall risk, I'm wondering, Dr. Bates, if you would like to take on talking a little bit about diabetes and fall risk.
Sure, you bet. And beyond, just the immediate effects of blood sugars is the long-term effects of diabetes and what this can do to our bodies, and our ability with strength, cognition, so to speak. It affects all of our senses. Our vision can diminish and be lost with diabetes, and this is over a long period of time. Also, nerve damage. If you can't tell where your feet are in space, are they on the ground? Are they a little bit off the ground? Are they on something that's hard, soft? We just never know. And so with diabetes, if we get up to move, our feet may be in a different position than what we think they are, because we can't tell because of that nerve damage. That message is not getting up to our brains. And so this can inhibit that ability to correct our balance, for one, and we misstep or fall or fracture a leg or hip very easily. This is a significant issue, and I think management around diabetes needs to be definitely a significant discussion with your care providers. And here we see some of the workshops around that. I don't know if you want to speak to that, Erin, but certainly.
I would love to speak to that real quickly, because Natalie happens to be one of our state's leading facilitators for this particular program. Remember that I work with the Disease Prevention and Health Promotion Program, which is primarily about education, and diabetes is one of those. So we have a workshop. It can be in person, like at a senior center or a library or something in your community, or offered virtually. That means anybody from anywhere can join in, which is great. But you meet for just a couple of hours a week over 6 weeks. You get to talk to other people, learn what they know, learn from yourself what diabetes does to you and for you. And I strongly recommend that you do this program. As a diabetic, I'll just reiterate what Dr. Bates was saying, which is, I was a diabetic at 5, and I'm now 54. Back then, we did urine testing. You put in a little test tube and shook it up, and the color told you up. But that was, old news. There are so many wonderful tools now to manage diabetes so that you can prevent some of these long-term complications that are so common, unfortunately. Natalie, if you can go to the next slide, because diabetes kind of leads us into pain, like Dr. Bates was saying. If you have neuropathy and you can't feel your feet, or you have the stabbing, burning pain in your feet, that's going to impact how you walk. So to tell us a little bit more about how chronic pain can impact our fall risk, we're going to turn it back over to Dr. Seeger.
Well, the primary implication of chronic pain is people stop moving because they hurt. I mean, we've all been in pain, so we don't want to move because it hurts. Ironically, for us as physical therapists, we are trying to lead the movement into reduce the use of opioids, and exercise can reduce chronic pain. It is considered one of the best medicines for pain out there is exercise, moving. For people with arthritis, osteoarthritis, the best medication for that is exercise, moving. For people who have constipation, don't take meds, get walking, drink more fluids and walk. And that will help with constipation. I mean, movement is one of the best medicines out there for all types of pain. Now, we fully understand that if you're in so much pain and walking makes it worse, maybe we should do something else, like get in a pool or use a stationary bike or something else. But pain in and of itself, because it limits how much you want to move, will start that negative cycle downward. that negative spiral to lead to more falls. Plus, when you're in pain, you don't pay as much attention to everything. I know I have this chronic back pain, and when my back pain acts up, I don't pay attention to things. And so I'm more likely to trip. I'm more likely to fall because I'm just not paying attention because all my focus is on my pain. And so realizing that, oh, wait, I'm in pain. Maybe I should be paying more attention to my environment instead of my pain will help. So chronic pain, there's some of these on this like shingles. Get the vaccination. I can't tell you enough. Get vaccinated for shingles. It is preventable now. And shingles is painful, but arthritis, it is exercise. It will decrease it. It really will. I can't tell you how much else to say about get moving. Erin?
You know what I like is that you say it like it is, which is, what else can I say? Get off your chair and move. It's pretty simple, isn't it?
Yeah, sitting will actually make your pain worse because you start focusing on it, and it will increase your risk of depression and all these other anxiety, which will make you sit more, which will increase your pain. And so if you get up, I have a niece who has some chronic health issues. And I turned to her one day, I said, I'm in chronic pain. You're in chronic pain. I'm going to be in pain whether I stay in bed or not. So I'm going to choose to get out of bed and live my life because I'm going to be in pain no matter what. And she, at that point, started getting out of bed and living her life again, realizing that I'm at a 5 out of 10 pain anyway, so might as well move. It didn't make it any worse. I'm still at a 5 out of 10. Yay. So live your life. If it does increase your pain, talk to your doctor, talk to your physical therapist, and we can give you tools to help decrease the pain while you do an activity.
Perfect. And like we've been saying, the healthcare team, whatever that means for you, is so important. And like diabetes, we actually also have a chronic pain workshop that teaches you some of those techniques, proper nutrition, how to relieve stress. And Natalie happens to facilitate some of those as well. So she does both of them, and we would love to have you join us when it comes to dealing with chronic pain from whatever the cause. Next slide, please, Natalie. All right, my friends, what this means is we are now ready to take your questions, and we get to talk to Mike. Mike, how are you doing? We haven't heard a word from you yet. You've been sitting in the background. Everything going well?
Yeah, everything's going well. I haven't heard a word from any of the participants either, or from any of the participants in the room.
Oh, you don't have any questions. Well, this is your chance. If you have a question, you can type it into the chat, and Mike will be sure to let us know. And there's lots of ways to do this. I think that's what we'll do for now.
Sure.
So we'll give you a couple of seconds to type anything out. Kind of as a review, remember some of the things that we've talked about is we started off with, what is a fall? How do we define a fall? Have I had falls? So I'm now more aware of whether I'm having falling issues. We talked about the physical impacts, what it can do, broken bones, skin tears, all of those things that we don't want to happen. But sometimes more importantly, we talked about kind of the psychosocial parts, that cycle of falling, as well as, especially now, this increase in social isolation, loneliness, and those things that we don't normally think of that can lead to falls do because of some of the things we're either doing or not doing, like getting up out of our chair and walking. So all of these things are interrelated. But I think the great news is that we've also been told over and over again that there are just a few simple things that we can do that will make us healthier overall, not to mention reducing our risk of falls. Any questions, Mike?
No, we don't have any questions, but I actually have a question, and maybe
good.
the panelists might be able to help me with
Okay.
this. So how's the best way to involve your pharmacist in your treatment, in your kind of your whole group of treatment providers, to make sure that they're part of the team? I mean, because they're kind of they live their offices in a different, or their business is usually in a different building than your doctor, and sometimes your therapist or any other of your other providers. So how can you involve your pharmacist?
yeah, you kind of go to the drugstore sometimes too, and you pick up the bag, but you don't ever interact. So
Right.
do either Dr. Bates or Dr. Seeger want to take that one on?
I have noticed a trend, and maybe it's just certain pharmacists or pharmacy chains that actually will engage a patient in conversation around their medications a little bit more than what we've seen in the past. Some states actually in the nation actually empower their pharmacists to be able to engage those discussions up front and actually seek treatment changes at that point of contact. So
Great.
it's
Okay.
not always up to just the physician anymore to make those decisions. That can be changed immediately with the pharmacy provider, which really empowers them. They are the most knowledgeable about all of your medications, and feel free. I would suggest just having that open conversation. If you have any concern at all that, hey, is this medication going to increase my fall risk, or you can have that open communication, and also sharing. Don't be afraid to share with your pharmacist what other medications or supplements, even as benign as you think they are. Just share, hey, I'm taking this supplement. Will this harm me in any way?
Oh, okay, great.
Be very helpful.
That's kind of what I was thinking too, Dr. Bates, is we have there is a pharmacist. Most of us deal with the pharmacy techs, who of course have some knowledge, but pharmacists, that's what they know. Absolutely know. And one of the things that's changing also is we have electronic medical records now, but sometimes our different healthcare providers may not know all of the medications we're on, whereas our pharmacists should, if we get them all from the same pharmacy. So they
Correct.
can maybe look at some red flags and things. But like Dr. Bates said, talk to them. Hey, I'm Erin. I'm here every month picking up this prescription. What can you tell me about it? Are there any concerns?
It's great. Thank you.
You bet. Did we have any other questions come in chat?
No, we didn't.
Well, I'll tell you, that's because we have these awesome presenters that lay it out there, give it to you straight, and you're going to be able to refer to that in your resource guide as we get ready to finish up. So, Natalie, let's go to the next slide, please. And this is really just a summary of everything we talked about. I know it's kind of small and hard to read, but we've talked a lot about this. Our goal for this particular presentation is why falls happen and how to prevent them. And I hope now you can get a feeling for the many reasons we can fall, physical environment, as well as our physiology and even our psychology, and they all interact in ways that are unique to us. But if we're aware of our environment and what the risks are, we can be proactive to prevent falls. And as we said, so many of these things are just good habits anyway. So I would like to, first of all, thank my panelists, because I know that every one of them is very busy. Last year when we did this, it was when everybody was locked down in COVID. And so it was really easy to pick a date and say, I'm free. These panelists are all dealing with the upswing in COVID issues in their own practices, and I know that they had to make some extra time to be here, so I want to be sure to thank them. I also want to make sure that we thank Natalie for her awesome polling and scrolling skills, and Mike for keeping an eye on that chat, even though it didn't come in, but he came up with a good question. Lastly, I would like to thank all of you for attending. It does mean a lot. And remember to go to the website, aging.idaho.gov/campaign/FPAM. And you can find the resource guide there. You can also find other falls resources. And we do have 3 more workshops coming up. They're all on Wednesdays. The next one is actually specifically designed for those that are medical, healthcare, PT, OT, CNA students. They have kind of a good foundation of the physiology and things, and also for professionals. So that one I'm really looking forward to. If you know anybody in that category, send them our way. And for all of you and your friends and family, on the 22nd, We have a seminar on how to identify your trip hazards at home and get rid of them. And finally, on the 29th, we are going to be talking about, and this will make Dr. Seeger so happy, talking about why we need to move. And we're actually going to have demonstrations of movements. Notice I'm not saying exercises, movements that everybody can do at their home, standing, sitting, all of those kinds of things to make sure we follow Dr. Seeger's advice and get out of our chair and just move it. So with that, thanks to everybody for participating and attending today. I'm Erin Olson, Idaho Commission on Aging. We are celebrating Falls Prevention Awareness Month, and I hope that you all have a falls-free fall.